I will present the screening of treatment and treatment of latent tuberculosis infection in health work in Maputo Central Hospital, the national reference hospital in Mozambique. Mozambique, as you know, is a high-burden country of TB. We have the prevalence in 554 per 100 habitant, and the MDR prevalence is around 3.5 new cases. Maputo Central Hospital is the biggest hospital in Mozambique. The TB is one of the top causes of hospitalization in medicine department, even in pediatry. And we have in 2014 361 cases in pulmonary TB and 183 cases in extrapulmonary TB. We still have a serious problem in diagnosis TB. Some of the cases pass in these studies conducting our hospital in 2015. We found in the 167 autopsies confirmed cases of TB, 41% had not been previous diagnosis TB. It's passed only if when clinicians didn't diagnose it. We conduct this study RASTAL, and with the objective was to establish the prevalence and incidence of latent and active tuberculosis in health work, and start the operation in characteristics of quantiferon and TST in diagnosed latent TB in Mozambique. The study was conducted in June to November 2013, and the population was the work of Maputo Central Hospital, which was more than 1 year in the hospital and without tuberculosis and we conducted questionnaire for demographic dates and respiratory symptoms, risk for tuberculosis, and history of HIV and TB. Chest X-ray was done and was read with radiologists and pulmonologists, and the TST was performed if he found more than 10 minutes was done quantiferon gold. If we found with our patient with productive cough, we collect sputum for vacilloscopy and culture and gene expert. In our study, we had 707 registered patients, and 758 was included. 68 was dropout, and 690 remained start, and of those 261 we didn't find any. We didn't find TB, and we found 4 cases of active TB at the screening, and 452 was possible infection TB. Of those, we offered them isoniazid prophylaxis. Our study, we had 75% of family, and the patient in the fourth has higher risk of TB. The worker which was in hospital more than 10 or more years was the higher risk for latent TB. And the prevalence of HIV was similar to the general population. And of the 125 of possible latent TB, we classified as higher risk 284, and 127 was at lower risk, and 14 was unclassified because they didn't get results of HIV. For those who have TST tests near for the cutoff, the concordance was low. And for those who have TST tests higher to the cutoff, the concordance of TST tests and quantiferon was high. We analyzed the risk for TB infection by department. We do the multivariate analysis adjusted for educational and duration of the hospital service. We found out that the department of surgery and laboratories and emergency and clinical care was the department that we have has risk for tuberculosis. 333 was offered isoniazid. This is old new diagnostic HIV and those which has high risk of latent TB. Of them, 234 was initiate isoniazid, and 99 deny to take isoniazid, and 181 complete 6 months of isoniazid, and 51 not completed the isoniazid, 5 because of side effects, and 46 abandoned the treatment. And we found 2 cases of tuberculosis extrapulmonary during this period. In conclusion, the prevalence of achieved TB in health work was 4 per 619. It is higher than the background prevalence, which is 553. And this suggests us the occupational risk. When we adjust the duration of the prevalence of latent TB was significantly high in several departments. This suggests also higher risk and help us to define the intervention, which department that we need to focus more the intervention for the prevention of tuberculosis. And for quantiferon, it was useful in TST tests 10 to 40 millimeters in HIV negative patient, and if it was more than 15 TST similar was similar diagnostic than to quantiferon. And isoniazid prophylaxis was well tolerated, but we saw that we have low acceptance during in our patient. And we found 2 cases of extrapulmonary tuberculosis were missing during the screening. Thank you. It's all. Yes, it's acknowledgement.
Thank you, Dr. Zindoga, also for this nice presentation and very important topic, especially because Mozambique is one of the countries with highest rates of HIV, and it's related with TB. So we can open for discussions.
Have other studies identified the high risk you found in the emergency department and the surgical subspecialties? Has that been shown? And do you have a theory about why that would be the case?
Yes, we think that this department, the problem is we have we have in our worker difficult to accept the that tuberculosis can be found in this area. if you see, this department does surgery, didn't manage so much patient with tuberculosis. In medicine department, all the workers know that here we can find tuberculosis, and they put it mask, they open the windows, but instead here didn't find tuberculosis. We think that this is ethical. That's why we are involved more in this time educational and to try to reduce this prevalence.
There was a recent study that came out in 2016 looking at residents and new incidents of tuberculosis in India. And they did look by department, and they found that pulmonary medicine, anesthesia, pediatrics, and general medicine were among the highest risk. And the surgical department was in the intermediate risk. So a bit different from our study.
Were you worried that, what was the timing of doing the quantiferon after doing the skin test? And were you worried that you might actually be inducing some false positive quantiferons by performing it after the skin test?
What was the time? Agar test. It can be possible because we done the skin tests after the 1 week, or we conduct the quantiferon. It can be we can induct the changing of quantiferon positivity.